According to the National Institute of Neurological Disorders and Stroke, back pain is the second most common neurological ailment in the United States. Only headache is more common. We spoke with Dr. Michael Gordon at Hoag Memorial Hospital Presbyterian in Newport Beach, who gave us more information on back problems.
The most common problems that I take care of on a regular basis are things like lumbar disc herniations, pinched nerves, spinal stenosis, and arthritic complaints of the spine. In the neck, the most common issue also, cervical disc herniations, and also a situation called cervical spinal stenosis, where the spinal cord is compressed. We see every once in a while a few spinal cord injuries which need surgery, but it's mostly the wear and tear phenomena of the neck and the lower back.
How can back problems be prevented?
So it's simple things: regular exercise, core strengthening exercise, good body mechanics, a work environment that doesn't engender back problems, but other really smart things. Keeping your weight to within maybe 10% of where it ought to be. Avoiding cigarette smoking. Most people don't realize how absolutely critical that is. And then just being smart about how we do our bending, stooping, and lifting tasks.
Dr. Gordon discusses the types of back problems that often lead to surgery.
As far as the patients who need a spinal surgery, it's usually somebody who has some type of very severe back pain combined with a neurologic problem, such as numbness, tingling, or weakness. So we're looking for the patients who will benefit greatly from the procedure with low risk. So we're actually focusing our attention on patients who have a very clearly defined nerve compression syndrome, hence the large disc herniation in the neck or in the lower back, the patient with a good degree of spinal stenosis or narrowing of the spinal canal, some form of significant instability in the spine where arthritis has generated a joint problem where the spine is no longer as strong as it needs to be and we have to reinforce it. Those would be the classic examples of patients who would benefit from an operation. As far as operating on someone with an achy, sore lower back, we wait at least 9 months or even a year before we decide that that's a patient who needs surgery. They'd have to be pretty miserable before we would even consider offering them an operation. There's so many other things that we would do first. I'm fond of telling patients that the backache that they had is going to last 99 out of 100 times about 4 weeks at the most. And maybe there's 1 in 300 patients who still has pain at 2 or 3 months. By the time that ache hasn't gone away at 8 or 9 weeks, that's when it's time to come in and to get some imaging. Our MRI scans and our CAT scans have come up 4 generations in the last 10 years. So we see things we could never see before. What does that mean? We know exactly what to treat now, as opposed to having to use a lot of guesswork and a lot of speculation. Our tools have gone from this big to this big. So the holes that we make, if you will, are about 1/3 or even 1/10 the size of what they used to be. That means less tissue trauma, more exacting surgeries, quicker recoveries, less damage to the adjacent levels. And that's made the biggest difference. The minimally invasive techniques, in theory, were fantastic about 12 years ago, but very difficult because the instrumentation we had hadn't evolved. Now, with Generation 4 and sometimes even Generation 5 equipment that I'm using, I take 5-hour surgeries and I've turned them into 1.5-hour surgeries. I've taken week-long hospital stays and turned them into 2-day hospital stays. 5-month recoveries have become 2-month recoveries. That's what we see as the biggest change.